Now we're live. Okay, live it is. Just a moment. Excellent. Just a moment. We should be going live. We are live now. Excellent. Okay. Just posting, and we should get down to business anytime soon. Okay. Very good. Okay, so now we're live. Okay, and I'm just going to start sharing my screen. There you go. Here we go. Okay, so again, I'm starting my my live session with Zoomax. And before I start, I'd like to thank and acknowledge Zoomax and Zoomax E-Academy, especially Jeff. He's been a really nice guy, and he's been setting up this with me for about 10 days now. I'd like to thank Zoomax Academy and their distributor here in Egypt, Bedr, and Dr. Muhammad Bayoumi for setting up this webinar. Okay, so I'm going to start by introducing myself. My name is Dr. Ashraf Rifai. I am an associate professor of endodontics at Al-Azhar University in Cairo, Egypt. I am also the director of the MRD endodontic program at Future University in Egypt. I'm the former head of department at Al-Azhar Endodontic University, Faculty of Endodontics. And I have been practicing dentistry for about 25 years, 26 years. And I've been a microdentist for 12 of those years. And I'm a proud member of the Excellence in Endodontics group, which is the logo you'll see at the bottom of the screen. And if anybody would like to communicate with me, you have my emails and my websites, as well as the QR code for my Facebook page. The best way to communicate with me is through Facebook. So if anybody needs anything after this session finishes, please don't hesitate to communicate. All right, so today's session is instrument retrieval. Is it that simple? Now, I know that Facebook, the University of Facebook, has created an environment where a lot of dentists post their cases, and they make it seem like instrument retrieval is very simple. It's something they do every day, 5 or 6 times a day successfully. But when I get these cases, all I'm thinking is, oh my God, how am I going to get this out? In my opinion, it isn't that simple, and I'm going to show you why throughout the lecture. All right, so this is a case. This is a preoperative case by my friend and my brother, Dr. Mu'taz Al-Khawas, and you can see here there was multiple instrument fractures. Sometimes from the preoperative instrument X-ray, we can actually tell what type of instrument is fractured. Sometimes we can't, but you can see here, this is a case obviously with two instruments fractured in different levels, one at the coronal level and one at the apical level. Sorry, one at the middle level. So what happens now? These three X-rays are actually instruments which I have fractured. So these are not referred cases. What I'm trying to point out is that even with the best instrumentation, even with a lot of experience, we still fracture instruments. And this should be put in mind so that you don't feel like it's such a nightmare. But when this nightmare does happen, what do you do? What happens when this instrument fractures? Basically, I remember the first time I fractured an instrument, I had a chill going down my spine, I started panicking, and my blood pressure was going up, I had palpitations. And that's basically what happens when you fracture an instrument, because you need to explain to your patient a serious situation has happened, and most of the time, most people don't know how to deal with it. And a lot of people deal with it differently. When this happens, they start burying the problem, and then after a while, you get a return from the dead and an abscess or a failure of your root canal treatment. And that happens more often than not, especially with general dentists and general practitioners who don't have the skills or the equipment to decide and to actually try and retrieve these instruments. Okay, so I'm going to start by showing a case. You have here a case of this was a lower premolar. She was a 32-year-old female that was referred to my practice for treatment, for initial treatment. You can see here, this is the tooth that wanted to be treated, the number 4-5. And you can see the tooth next to it was not my treatment, but the dentist had fractured or an instrument had separated at the apical area, which the dentist was unable to remove. Patient had no medical history, and she was basically referred because of this complex anatomy. You can see an abrupt curvature here, and you can see a deep split in the anatomy of the premolar. So immediately when I get aberrant morphology or something that's out of the normal or the ordinary, I immediately go for a Cbct. And this is the axial view of the Cbct. You can see it moving apically, and you can see there are actually 3 root canals and a lateral lesion. Again, we can look at that. So that's the axial view. I'm going to show it again. There you go. You can see a trifurcation, a separation into three separate root canals. And again, you have here you have the sagittal cross section. You can see the root, and you see the very big lateral lesion right there. And you can see that very clearly. And you can see the 3 roots, or the 3 exits of the roots. There you go. If you look very closely here, you will see a lateral exit right there. That's where there's a lateral exit. That's why the lesion is on the lateral surface of the tooth and not apically. And then the other Cbct here, you will see another one. This is the coronal view, and it's very obvious that one of the roots is actually extending into the mental foramen, just right there. So this was quite a very complex case. You have a mid-root trifurcation, 3 roots in a premolar, and you have lateral exits. You have also a deflected root or a curved root. So this makes it quite a tough case, although it's a simple premolar. So this patient was referred. She was the daughter of a dentist, so I was being very, very careful. And I started doing my preoperative, and I started taking my working lengths. And then during the instrumentation, what happened? I had an instrument fracture of an SC2 instrument from the Revo S system. It was out of the box, and it was a new file in a straight portion of the canal. So what we had here was a situation, again, just as everybody else in these situations, I began to panic. I started sweating, and then I started thinking, how am I going to deal with this? So in this case, I started preparing and dealing with the other 2 canals first. and I had them obturated, and then I was left with this instrument. It was still there. So I attempted a bypass, and here you have an X-ray very clearly showing the bypass right here. That's the instrument, and that's my size 15 bypassing the instrument. And then this is your preoperative, your intraoperative, and this is your postoperative. As you can see here, it appears as if I did not finish preparation in that part of the canal. But if you remember from the Cbct, there was a lateral exit to this, and that will become evident when I show you the postoperative. This is immediately postoperative. And this is 2 years later. You can see there's no radiolucency in the apical area, and the lateral lesion has healed completely. See that? So this indicates that really there was a lateral lesion here and not an apical one. This restorative work is not my restorative work. I think a doctor actually did a perforation here during restoration. This was my immediate post-operative, and I had just seen her, so I took a post-operative X-ray just to make sure that everything was healing fine. Okay, so when something like this happens, when you get an instrument that fractures during your treatment, what are the possibilities? You have 4 possibilities. You have the trilate removal, you have bypass, apical surgery, or just obturate over it. Now, the obturate over it option is the easiest option, and the problem is that it's not really substantiated with evidence. So the question goes and remains, why not obturate over it? 2 reasons. Number 1, you have to remember the problem is not radiographic in nature, it's bacteriological. The purpose of my endodontic treatment is not to create white lines on X-rays so I can show off on Facebook. No, it is to effectively clean the root canal space, which is irregular by all means, and to eradicate as much of the bacteria that is present in this root canal system. Now, to bring things down to size, a size 8 file is equivalent to 800 microns, and the size 40 file is equal to about 4,000 microns. And one bacteria has the size of about 1 to 2 microns. This should bring things down to size. So any space which is left inside the canal, which is unclean or unobturated or unprepared, has the potential to harbor very large amounts of bacteria. So when you come to discuss this with other people who don't really believe that there's a problem if instruments can be obturated over, they have 2 arguments. The first argument is the instrument separated at the apex. The second argument is the instrument separated after complete preparation. So I'm going to spend a couple of minutes trying to refute these arguments. The first argument, the instrument is as if it was a filling material. And if you see here, what do you see on the sides of these instruments? Sorry, space. See that? There you go. Space. This space, if it's evident in the X-ray, is space nonetheless that may contain bacteria, that may harbor bacteria. So instruments which fracture inside the canal, even if the canals are totally, we will put between quotes, totally clean, which is not possible, they still do not act as gutta percha because simply there is space between the flutes that may harbor bacteria. And you can see from all the different cross sections that I just showed on the screen, all of them there's potential for space between the instrument and the canal walls. Not only to mention that canals themselves are not necessarily round. This is also a misconception. Just because you inserted a rotary file inside the canal and prepared the instrument, the canal, that doesn't mean these canals have become regular tubes or regularly circle in cross section. So you can have an irregular canal, and you can place in a regularly tapered instrument, and there will be a discrepancy between the canal walls and the instrument themselves. This is a study by Verma in 2011, very old study, but you can see from these micro CTs of the mesiobuccal morphology of the first molar, maxillary first molar, you can see how complex this anatomy can be. The best of us, the best endodontists, may fill one or two of these ramifications, but in no cases can we actually obturate and fill every single ramification in these complex anatomies. So this leaves a very high potential that even if you were able to clean the canals somewhat, there are still areas of the canals which are not clean even after your best efforts at irrigation and enlargement of the canals. Again, let's look at some of the research. Vienna in 2008, Rocas 2013, and Rico Romano in 2016. These are all bacterial reduction studies where basically the researchers have taken teeth. They clean out these teeth with the different methods of irrigation and preparation, and then they take swabs from these canals to make sure that they are without bacteria. And although we have some very, very good irrigation techniques and chemical-mechanical preparation techniques, none of these studies have shown 100% eradication of bacteria in their studies. So this leaves us to question that there is always probably a level of bacteria in the canal which has not been eradicated. So which one do we choose first? Trilat removal, bypass, apical surgery, or no, not obturate over it? Definitely not. So we have trilat removal and bypass and apical surgery. These are the three options which remain when you have an instrument which is separated inside the canal. Now, I always get told bypassing is the treatment of choice. It is the treatment of choice, and for many reasons. And I know it's not generally the most loved treatment of choice for dentists. When a dentist or an endodontist has an instrument which is fractured inside the canal, and he's taken an X-ray, an intraoperative X-ray, and he sees that instrument, his most wanted wish is for this instrument to be removed and taken out of that X-ray. So bypassing is usually not something that the doctor wants to do. He would prefer to remove it. But this is the emotional choice, and this is not the best choice for our patients, because research has shown that whether we bypass the instrument or we remove them, if we close off our main portals of exits of these teeth with properly obturated fillings, the success rates of bypassed files or of files which have been removed are the same. So here, bypassing is the treatment of choice, and for the following reasons. It's less traumatic, less expensive. It doesn't need complex technology. You can do it without a scope, even without loops. And in some cases, if you're lucky, the instrument pops out. So I get always asked about the protocol you use for bypassing. And I have a simple answer to that. It requires small files, minimal application of force, and a lot of patience. When you are trying to bypass an instrument, you don't create a new canal. You try to enlarge already existing space between the instrument and the canal wall. Sometimes you can find this space and sometimes you cannot. If you begin to start your procedure with the intention of drilling next to the fractured instrument, then you are probably going to perforate this root. So here, this is a case. This is a very, very tough case. This was an upper 6. And you can see in X-ray number 1, an instrument fractured ahead of the curve. I started finding space between the instrument and the canal walls. In X-ray number 3, you can see me reach beyond the instrument. Then there's my master cone, and then these are my final X-rays. Okay, so yeah, it can be done. It's not always possible, but it is potentially possible. Okay, so here you have another case with, I'm going to show you the video of a tooth. There you go. This was a tooth, an upper premolar, which a doctor referred to me with an instrument fracture in the buccal canal. And you can see that after some effort, I managed to bypass that instrument. You can see the space between the instrument and between the canal. The space between the instrument and the canal wall. And here you can see an instrument inserted in this space. That's a size 25. So I actually managed to enlarge the canal to a size 25. Usually if this happens, As a dentist, you should do one thing and one thing only, and that's obturate. But I was still a little irritated that there was an instrument inside the canal, so I used my rotary file in an anti-clockwise motion. This anti-clockwise motion resulted in me loosening that instrument, and I managed to get that instrument out. Now, I would say 95% of the time, if I did that, I would probably push the instrument back into the canal. So it would seem very logical for you never to do this. This is a situation you should never do at home. It is very risky to try and remove that, because I've had experiences where I've actually pushed the instrument back into the apical area, and it made my life much harder when I had to either bypass or remove. So in the case of a bypass, be happy that you bypassed. Don't try to do anything else. All right, so the order of things are bypass first, then trilate removal, and then if all else fails, apical surgery. So here remains, when should I try to remove or retrieve these instruments? So when should I try and retrieve them? When you have the proper technology available. You need a lot of technology. You need microscopies to aid in your vision. You need ultrasonics, as well as specific instrument removal systems. When you have the experience, when you first start trying to remove or bypass instruments, you should start with easy cases, and then build up your repertoire, and bit by bit start doing more complex cases. When the instrument is ahead of the curve, and this is very, very important. If it's beyond the curve, you have an issue. Now, what does that mean? This is also something which is very important for referring dentists, because I get a lot of dentists refer their cases to me when there are separated instruments inside the canal, and they misunderstand. They believe that any instrument fractured at any level of the canal is easy to remove and is removable or retrievable. So when you have an instrument which is fractured within the line of sight, that's generally removable. But if the instrument is fractured beyond the line of sight, then we have a problem. Then I can't see it, and what I can't see, I can't do. Now, the second issue here, which I'm going to touch on in a few moments, is when there is sufficient remaining dentine thickness. And this is something that a lot of people don't look at their preoperative x-rays when they refer these cases. You have to look at the thickness of the root. Some roots are really thick, because the process of instrument retrieval requires that there be some level of dentin laterally to allow for some enlargement, so that you can apply your methods of removal or your instrument retrieval technology, and then have space for the instrument to come up inside the canal. I've seen some instances where dentists have applied the instrument removal technique directly over the instrument fractured segment, and this doesn't make any sense, because if you apply the instrument removal system on top of the instrument segment, there will be no place or no way for the instrument to come out. So any application needs to be lateral to the instrument and not coronal to it. And you can see, depending on the level of the instrument fracture, the amount of remaining dentine thickness differs. Now, I'm going to show you a case here that I did maybe 2 months ago. This was a 45-year-old female referred to me for instrument retrieval. And as you can see, the instrument was fractured in the mesiobuccal canal. You have a very large piece of the instrument, and it's fractured in the junction between the middle and the coronal segments of the root. And as always, whenever in these cases, I immediately send out for a Cbct. And you can see this is the sagittal cross-section. That's the picture of the instrument segment inside. This is after enlargement coronally a bit, so that I could view the fractured segment. And you can see its position, and from the coronal section of the Cbct, you can also see that it's generally in a not so curved canal. The canal is curved in the buccolingual dimension, but it's quite straight in the mesiodistal dimension. But still, as you can see, I can see all the periphery of the instrument. And somebody would say, why didn't you bypass? I did. And the referring dentist tried to bypass, and he was unable to get any further than that. And after trials at retrieval, you can see here an X-ray showing me bypassing the instrument and actually overextended into the apical area. And that picture shows the segment. It's about a 6 mm segment of a martensitic rotary nickel titanium instrument. And I was fortunate enough to be able to remove it. But when I took a closer look, I realized that during my retrieval, I actually perforated into the forcation area, and you can see very clearly here on this picture this mouse hole appearance. You can see that the perforation laterally, that's inside the canal, and that's corresponding to the X-ray that you see and the position of the perforation that you see in the X-ray. But generally, I knew that there was a risk for this. I didn't show you that, but I knew that there was a risk for this. That's why I always take my Cbct scans. And I explained to my patient that you're referred, yes, everything is good, but you have to realize that there is a risk that during my retrieval process that I may perforate. And I measured the amount of remaining dentine thickness between the mesial root and the forcation area, and I measured it to be about 0.59 millimeters, and in the axial at the middle area about 0.69 millimeters. So there was quite a high risk of me perforating, because the minimum enlargement that I may do when I'm trying to retrieve an instrument is about 1 to 1.2 millimeters. So there's a very high potential risk for a perforation, and I explained to my patient that that may happen. And then I repaired the perforation, and these are my master cones, and I started doing the distal here, the distal canals. I was concerned mostly about that area and repairing that perforation. So I placed in a temporary gutta percha cone to act as a place maintainer during the perforation repair. And then this is my post-operative. Although with my best efforts, I had overextended for about 1 millimeter. But as you can see, I did repair the perforation here, and I'm looking forward to following up these cases in the next few years and to see how much bone loss happens in the forcation area. So what needs to be mentioned, that in a case like this, even though I could remove it, there was the limitation of the fact that the roots themselves were very thin, and that could result in another iatrogenic error during the instrument retrieval process. And I had explained to my patient that in the case that this happened, we may need to consider that the success rate of this tooth over time may be less. The reasons why, in my opinion, the dentist fractured this instrument, simply she had a very limited mouth opening. She would only have about maybe 1.5 centimeters between her incisors, and working in the molar area was very difficult and very cramping for me. So this took me quite a long time to reach this end result, or quite a number of visits. All right, so what plays into the success or into the failure of my retrieval attempts? Obviously, the position of the instrument fracture. If it's fractured in the coronal area, it's different from than if it's fractured in the middle area or it's fractured in the apical area. Coronally, you have more dentin lateral to the instrument, and it's much easier to reach. It's not further into the canal, so you're not as constricted when you're trying to remove it. What the big advantage is that it's easier to remove in the coronal, and the further you go apically, the more it becomes harder to remove and more difficult. Also with the possibility of perforation laterally, or in some really nasty cases, actually pushing the instrument into the apical area. Size and length of the separated instrument, and my friend Yoshi Toriyoshi, he's done a lot of research on this, about the combination of size and length and its capacity for removal. Basically, the end result of this his work was that long, thick instruments above size 30 probably require tube systems or loop systems for removal. Instruments which are less than 3 millimeters and less than a size 25 can be removed with ultrasonics. He's done a lot of research on this, and it's very, very amazing, because he's also combined using different types of lubricants or media during the instrument retrieval process, EDTA, different types of oils, and he's come up with some very fantastic results. So whether you're using a loop or a tube system in its removal, and I'll be discussing those in a few moments, the length and the size of the instrument makes it harder or easier to come out. Smaller pieces of instruments are relatively easier to come out. They'll come out with ultrasonics, while longer ones and bigger files will probably require to be pulled out because they engage more with the lateral dentin. This is pictures from the paper for my friend, Dr. Ahmed Madrati. And this also highlights a very important thing, and the factors affecting success. So in this case, you can see an instrument fractured within a round-shaped canal and one fractured within an oval-shaped canal. Obviously, the original cross-section of the canal makes a difference. The more irregular it is, the more space you will have lateral to the instrument, and the easier it may be for it to be removed. The instrument design and cross-section, this is also very important. If you look back at our, the more recent instrument designs have very large helical angles. That means, to make it a little simple, the spaces between the flutes are much larger, and the flute space is much larger. That means even in case these instruments engage with the dentin, there's still a lot of space in the flutes to allow for passage of instruments in the case of bypass or trials at removal. So instrument cross-sections make a difference. If you have, say, a regular triangular cross-section here, it will have more space laterally, while if you have a modified convex triangle, like here, here you will have less space, and it will be harder to nudge an instrument in between the instrument and the canal walls. Also, the material of manufacture is an issue. I prefer removing stainless steel instruments, because when you use ultrasonic instruments on NiTi instruments, they tend to chip off and break, while stainless steel instruments are more robust. When you use ultrasonics around them, they don't absorb the energy, and they don't fracture and chip off as nickel titanium instruments do. So in general, stainless steel instruments are a little easier to remove than NiTi instruments. Another issue is the type of instrument separation, and this is something that you should consider. Instrument separation differs. It can be bound or unbound. And what does that mean? It means the nature of the fracture. Some instruments fracture inside canals when they're relatively loose. So these instruments are unbound. That means the amount of dentin in contact with these flutes are much less, and the amount of engagement of the dentin is much less. On the other hand, you may have a bound instrument, and this usually happens when dentists try to force instruments inside canals. These instruments bind much more aggressively with the dentin and are definitely a lot harder to remove compared to unbound instruments. Now, this was an example of a tooth with an instrument separated. It looked like an edge file. It's very obvious. It looks like an edge file. I'm just going to blow it up here. You can see it looks like, you can see the typical edge file shape. And if you look very closely, you can see that there's actual space between the instrument and the canal. And this was the case when I looked down into this canal with my scope. I could see a lot of space, and I spent about 2 or 3 visits trying to remove it, and I failed. Now this brings me to the point that this is about 4 millimeters of an instrument, and it was a size 45. Although there was a lot of space behind it, the nature of this instrument, it being an H file which engages aggressively in dentin, and with that size, a size 45 with the 4 millimeters, it made it nearly impossible for me to take it out with ultrasonics. In this case, I removed this with a tube system. And I just wanted to show, just out of curiosity, if you can see Here, this is the preoperative. This looks like the outline of a tapered stone, a tapered diamond stone with a flat end. And before this general dentist referred this case to me, it seems to be he inserted a diamond stone into the canal to try and retrieve this instrument. Honestly, it was a very risky behavior. I don't know what he was trying to get out of it, because even if he had reached that instrument, he had no other instruments to try and retrieve it out of. Luckily for him, he did not perforate. But even though this happened, you can see that even after my retrieval attempt, the amount of damage to the root canal walls is substantial. And this brings me back to the point I mentioned at the beginning of my lecture, is that bypass is still preferred to instrument retrieval, because the amount of damage that happens inherently during instrument retrieval is quite large. Okay, now let's look at the research all the way down to 2014. So this is not really new research, but generally at least 6-7 years old, and it hasn't changed much since the 1999. So in 1999, research done on instrument retrieval, 48.7% of cases which were chosen for bypass were successful, compared to 19.5% for retrieval. So out of every 10 cases, the dentist chose for retrieval, he could only remove 2 of them. Again, this in 2012, the research shows about 54% success in retrieval and 30.9% success in 54.4% in bypass and 30.9% in retrieval. Again, you can probably blame the difference from 1999 to 2012 on the level of technology, the application of microscopy, and the use of ultrasonics, which weren't readily available in the 1999. In 2014, unusually, you have this is a research done in which the success for bypass was 85% out of 45 clinical cases, compared to 36% of instrument removal or retrieval. For me, 85% of cases successfully bypassed is not a number which I reach in my clinic. The number in my clinic would be about similar to the research of 2012 by Navarez. About 50% of my cases I will be able to bypass, and about 30% I'll be able to remove. And these numbers are very important for the general dentist to know, because a lot of these general dentists, they refer cases which with the pre-intention to tell their patient that send them over to the specialist will be able to remove it. And I just wanted to bring it down to size. We can't remove every single instrument that comes to us. Okay, so what are the techniques that we use to remove separated instruments? You basically have 2 basic techniques now. You have ultrasonic vibration, using thin ultrasonic tips to trough around these instruments and try to vibrate them out and just let them jump out of place inside the canal. And you also have specific instrument removal kits, which are designed. Now, these are broken down into two main branches, which are tube systems, and the other types are lasso systems or wire systems. And I'll explain both in a moment. So here, this is a case I did a very long time ago. It was about maybe 12 years ago. And you can see from the level and the graininess of the video that it was a very long time ago. We didn't have the high definition cams that we have now. And this was an instrument fractured in the middle third. And in this case, I created a platform, and I started applying my ultrasonic instruments laterally to loosen that instrument from the canal. And hopefully it should pop out anytime soon. Here you go. Yeah, so that's use of ultrasonics. Then you have, like I said, specific instrument retrieval kits. You have tube systems and you have loop systems. For instance, the Zumax system for our sponsor company, this is a tube system. It comes with different sizes of tubes. And basically what a tube system is that it has a tube with an extension or a wire inside the tube, which the tube is placed over the instrument segment, and then this wire is activated and engaged so that it pushes the instrument into the tube wall, engaging with it and allowing the instrument to be pulled out as part of the tube. And I'll show you what that means right now with the system. Okay, so when we do this instrument, when we do in removal, we have to create a platform. That means we need to intentionally enlarge the canal above the level of the fracture. And usually we do this using either rotary night-eye instruments, or I prefer gates. And these gates are modified so that that portion of the gates is flat, and you actually intentionally create a ledge above the instrument fracture. And this video is the sponsor's video. This is not my video. I've done my own, but this is specifically from the Zoomax extraction system. And you can see all the way around. Here, this is a specific Trephine drill, which then it's a drill which has a space in the middle, and it basically creates space around. Now, you don't necessarily need the Trephine drill. You can use ultrasonics to enlarge the space between the canal wall and the instrument, but it takes an immense amount of time. Using these Trephine drills, it's much quicker. Here, the tube is inserted, engaged, activated, and the instrument gets pulled out. There you go, see? Because it's become engaged inside. And this is called a tube system. Now, the problem, as you see, that there is an immense amount of damage that has to happen to the wall for you to be able to remove it. And as I showed you in the previous cases, if this damage is in a very thin area of the root, you may perforate. So that's why, again, that the treatment of choice would be bypass whenever possible. Now, on the other hand, you have the loop systems, like the loop systems for the Toriyoshi instrument removal system. Now, this is a little different. This involves having a very thin tube with a thin wire, and the wire is looped inside. And there are many different variations to this type of system, but basically it is like a hangman's noose. And again, you still need to create space around the instrument. Then the loop is carefully placed on the instrument, activated and tightened around the instrument, and then it's pulled out. And as you can see here, this is a blown up picture. It's very grainy, but basically you have the loop system, the tube with the wire loop engaging the separated instrument. And then, and in the end, when all else fails, sometimes, some cases, instruments pushed out of the apex, even instruments at the apex, are not removable. Not all cases can be removed simply and easily. Some cases need to be removed surgically, and that's a story for another day. The surgical treatment of unretrievable instruments. Again, I would like to thank Zoomax for giving me the opportunity to be with you today and to be able to share with you some of my information and some of my cases and my knowledge. And I hope it was useful to everybody who was watching this. And again, thank you so much for your attention. And if anybody has any questions, I think you can ask it on the Facebook page, and I'm more than willing to answer your questions. And thank you so much for your attention. Okay. So if you have any questions, please don't hesitate to just post on Facebook, on the Facebook page, and I'm more than willing to answer. I had one of my questions that was, please recommend kits for retrieval and loops for beginners. The problem is, before you start trying to remove instruments, I need to ask a question. If you could post that on Facebook, I'm sure Jeff will pass on the answer. Do you use magnification? Do you have a microscope? Do you use loops? And if so, what level of magnification are you using? And then I may better ask you questions. I can recommend cases of different systems offhand, but I prefer if you communicate with me by Facebook Messenger. It would be better because our sponsor, Zoomax, has their own extraction kit. It's called the Zoomax extraction kit, and it's a very good kit. I have one in my clinic. But they're not the only ones. And with regards to a beginner or not, it really doesn't make a difference. If you've reached to the point where you're going to purchase an instrument retrieval kit, you need to have some level of experience at instrument retrieval or bypass, and you probably need to have a microscope before you even venture to try and purchase an instrument retrieval kit. I've had some dentists talk to me about trying to remove instruments without magnification, and that is gross negligence. You should not try to remove an instrument if you cannot see what you're doing, and no amount of money will actually give you a successful removal, a safe, successful removal for your patient if you can't see what you're doing. Yeah, I was asked what kind of oil do I use. I've used synthetic. This is a question for when instrument retrieval occurs. I'm just going to touch on this. When you're removing instruments, you sometimes apply a fluid inside the canal to allow for it to penetrate between the instrument wall and the instrument and the wall. And a lot of research has been done on using olive oil or synthetic oil. I either use synthetic oil or olive oil, and then I switch from dry to wet. The problem is that when you're applying ultrasonics inside a canal with moisture or wetness inside, your visibility is nearly zero. So you alternate between using these ultrasonic instruments in a wet environment and a dry environment. I was asked about the Trephine drills. The Trephine drills are a very nice toy. Yes, these Trephine drills come with the kits, but they are sold separately with different sizes. The sizes correspond to the different sizes of the tubes that are available in the system. So be sure to coordinate the size of the Trephine drill and the size of your extractor. Because if you have a thinner Trephine drill, you won't be able to get the tube in after it. Another question, I think I answered that during the session. Should we leave a broken instrument inside the canal, or is it mandatory to remove it? The research is that success rates over time have shown that the failure occurs if instruments are not retrieved from the canal. The degree of failure is what is questionable, but failure does happen at a higher rate than if the instrument is not retrieved or bypassed. I have a very smart question I got asked right now. How can I decide what type of loop is the right one for me and the right choice? The problem is that recently we've seen many different type of loop systems in the market. I've tried 2 or 3. My experience with the loop system in general is that they are not as strong as the tube systems. because they tear. If the instrument is very highly bound inside the canal, these loop systems depend on wires which are 0.3 millimeter in diameter. So even if you apply a little force onto them, they break. Although there have been trials to create better alloys for these wires, which are more resistant to fracture, but still, the only way for you to honestly to try and make your own opinion, because I've had some of my colleagues tell me that they like a type which I didn't like, and or I like a type which they didn't like. So the only way would be for you to buy one, give it a try for a couple of maybe a year or two, and then if you see something that is more to your liking, then you'd switch after a while, because they do still have a life expectancy, and they get bent and they fall and they break, and so you're not going to have it forever and ever. Yeah, and I was also asked one more question, Jeff, before we shut off. How to choose the right magnification? I don't know. I don't know what it is with regards to magnification, but instrument bypass can be managed with a very minimal magnification, 3x, 5x. But if you're going into instrument to retrieve an instrument, you need to starting from 16x and above, so that you have enough visibility of the field of view, so that you can make a proper attempt at retrieval without damaging too much of the tooth structure lateral to the instrument. So I would say 16x and above for instrument retrieval, unless it's flush at the orifice, then you don't need that much magnification. Okay, Jeff, any more questions? Okay, so my moderator has told me that the questions have finished. I know that he was telling me that most people in China are going out to have fun today, because it's Friday and night at 8 p.m. there, so everybody goes out before the weekend. And I understand that that's also Jeff wants to go out and have some fun. So I'm going to say goodbye and thank you for listening. And I hope to see you soon. And again, one more time, I would like to extend my thanks to Zoomax and Bedr Company for hosting me today. And if anybody has any questions at any other time after this, this is going to be up for a while. Please don't hesitate to communicate with me and ask me any questions you are here on the Facebook page or directly through my messenger. And thank you so much for your time.